back to my channel. Let's read Toronto Notes 2025 edition, and today I'm going to do the pediatrics section and some important topics from pediatrics. Okay, the first topic I'm going to cover right now is approach to infant or child with dehydration. Okay, so what is the cause? The cause may be either there is a decreased intake or increased loss. So decreased intake means poor intake during illness, or maybe some problems with the breastfeeding or some eating disorders. Then increased losses include common sites include loss from the GIT tract like vomiting, diarrhea, bleeding, from skin or mucous membranes like fever, burns, hemorrhage, urine osmotic diuresis, diuretic therapy means certain medications, diabetes insipidus, post-obstructive post-ATN recovery diuresis and respiratory tract like tachypnea, bronchiolitis, pneumonia. So we don't have to remember each and every word, we just have to have a concept that a dehydration can occur in the child whether there is decreased intake or increased loss from the body. Decreased intake either in the form of poor feeding, either in the form of eating problems, feeding problems, okay, and the increased loss either because of certain infections, nausea, vomiting, diarrhea, then burns, then in certain conditions like respiratory tract infections, they can lead to increased loss of fluids from the body. Okay, next thing is we need to know about the total body water. The 2/3 is in the intracellular compartment and 1/3 is in the extracellular compartment. Alright, okay, so what next thing we need to know that the third spacing, the intravascular fluid, that is the 1/4 of the total body water. Of basically the extracellular fluid is divided into intravascular fluid and interstitial fluid. So what they say that the intravascular fluid movement into a third space not in equilibrium with extracellular fluid can occur in edema, liver failure, malnutrition, increased vascular permeability, bleeding. So all these things can also lead to dehydration. Management of dehydration is like if dehydration is suspected based on history, then what we have to do? We have to do to determine the degree of extracellular volume contraction. So we have to assess basically the degree or severity of dehydration. Okay, so we have to see whether it is mild dehydration is here, moderate is there, or severe is there, right? Assessment of severity of dehydration can be done by C base H2O. That is a mnemonic to remember all these things. Yeah, I know it's quite a big table, but mnemonic seems better. So C is capillary refill time, B for blood pressure, A for anterior fontanelle, we need to check it, then skin turgor, then sunken eyes, then the heart rate, sunken eyes, then the heart rate, then oral mucosa involvement and urine output. Okay, so we need to get an idea that severity of dehydration can be assessed with the help of all these factors. So they say that if the weight loss less than 2-year-old child, if 5% weight loss is there, then is mild, 10% moderate, severe, 15%. And if the child is more than 2 years, 3, 6 and 9%. Okay, so there is some degree of weight loss, mild, moderate degree of weight loss, moderate, severe weight loss, then is definitely severe. Then the pulse may be rapid or weak in case of severe dehydration. The blood pressure is going to be decreased if the child is suffering from shock and is very dangerous. Then the urine output definitely is decreased in mild, markedly decrease in moderate, and urea, no passage of urine in severe. Oral mucosa slightly dry, in moderate it is dry, but in severe is parched, extremely dry. Then anterior fontanelle is sunken in moderate but markedly sunken in severe. So eyes will be markedly sunken, fontanelle will be markedly sunken in severe dehydration, and skin turgor is going to be tenting in severe, and capillary refill time is increased more than 3 seconds in case of severe dehydration. So now I tell you a scenario that a child presents to you with a blood pressure of 80 by 40, and there is no urine output, means the mom is saying that he has not wet his diaper since morning, and the eyes are extremely markedly sunken, and the anterior fontanelle is markedly sunken. Eyes are extremely sunken, and the skin turgor is also very decreased, extremely decreased. The sunken anterior fontanelle, sunken eyes, blood pressure quite low, and capillary refill time is 5 seconds, and there is very extreme dry oral mucosa and no urine output since morning. How will you classify this child? This will be classified as severe dehydration. That's right, severe dehydration. Now determine the likely electrolyte disturbances. Next thing we need to see that depending upon etiology of dehydration and type of fluid loss, either there can be isotonic versus hypertonic versus hypotonic. Okay, now also we need to see that whenever dehydration happens, what is they say that for moderate and severe dehydration, initial investigations include basically urine output analysis and blood work. We have to look at certain electrolytes, sodium, potassium. The three main electrolytes need to be checked in case of dehydration, that is sodium, potassium and chloride. Alright, and then also we need to check the glucose, the acid base disturbances. Then we need to check the blood pH, partial pressure of carbon dioxide, bicarbonate and impaired renal function. We need to check basically urea and creatinine. Alright, electrolyte content of various body fluid. We don't need to remember this table definitely. We just need to remember that whenever dehydration occur, there will be derangement of sodium, derangement of potassium, derangement of chloride, there will be derangement of acid-base balance, blood pH, partial pressure of carbon dioxide, partial pressure of bicarbonate, impaired renal function, urea creatinine gonna get high. Now the third thing to assess dehydration is determine if the child requires paroral, nasogastric or IV rehydration. Okay, so dehydrated child must receive adequate fluid management. Of course a child is dehydrated, but we need to give first line treatment would be definitely fluids, including replacing deficits and ongoing losses, and also there can be given maintenance fluids. So basically bolus fluids and maintenance fluids both can be given. So the next thing is ORT indication. ORT indication means mild to moderate dehydration. If a child is suffering from mild to moderate dehydration, the advantages can be there will be decrease, then we have to give ORT, oral dehydration, especially even you can see in this table. There's a very good table here that classifies degree of dehydration into no, mild, moderate and severe. Here you can see that no dehydration, we will not give any other specific thing except from the age appropriate diet and replace the ongoing losses. On mild dehydration, we have to rehydrate with oral rehydration therapy and age appropriate diet again after dehydration. Moderate dehydration, rehydrate with ORT, and the rate is a bit high, 100 ml per kg over 4 hours. In mild it is 50 ml per kg, in moderate is 100 ml per kg over 4 hours, rest is the same. And in case of severe dehydration, always remember we have to give IV fluids to the child with normal saline 20 ml per kg bolus. First bolus is given, then reassess, repeat if necessary, and then we have to give the oral dehydration therapy when the patient is stable. First IV fluids, IV bolus is given, normal saline is given, and then when the child becomes stable, then we have to give oral dehydration therapy. We have to replace the ongoing losses with oral rehydration therapy and age appropriate diet after rehydration. All right, now let's see again what is the advantage of giving oral rehydration therapy. So we saw that in mild or moderate dehydration we don't give IV fluids, we only give oral rehydration therapy, that is low cost. No increase in incidence of iatrogenic hypernatremia or hyponatremia and parental involvement. So basically we have to give oral dehydration therapy with the help of parents as well, and we don't have to increase the risk of hyponatremia or low sodium or high sodium. All right, then the indications for IV rehydration therapy, as we already saw that the severe dehydration in which we give IV rehydration therapy, and frequent assessment we basically check the electrolytes, and if the child is excessively vomiting, he's suffering from diarrhea, and his mental status changes, he cannot tolerate the oral fluid, so therefore we have to give IV rehydration. Okay, and we are not able to provide oral rehydration, and persistent vomiting or diarrhea can be indication for IV rehydration. All right, this table we already discussed. Then special consideration in SIADS, that is a syndrome of inappropriate ADS secretion, the clinical signs include hyponatremia, low sodium, excretion of concentrated urine. While it's the opposite in case of diabetes insipidus, where there is hypernatremia and excretion of extremely dilute urine. Okay. Next thing we need to know about number 5 point, provide the appropriate fluid electrolyte maintenance daily requirements. Okay, there are different rules we need to follow. First rule is 150-20 rule for the maintenance fluids, and the other rule is 4:2:1 rule, hourly rate of maintenance fluid. Okay, for first 10 kg of body weight, 150-20 rule is there. 100 cc per kg per day, and for then 50 cc per kg per day for every kg, then for 20 cc per kg per day for every kg if more than 20 kg. Okay, so what they want to is us to remember that 150 and 20 rule. For first 10 kg 100 cc, for next 10 kg we have to give 50 cc, for next 10 kg 20 cc. But 4 is to 10, 2 is to 1 rule is more easy. The first 10 kg 4 cc, then the next 10 kg is 2 cc per kg per hour, and next if the weight is more than 20 kg, then 1 cc per kg per hour, 1 cc per kg per hour. All right, so 4 is to 2 is to 1 rule is there, and 150-20 rule is there. Okay, we can now discuss more about it in a couple of minutes. All right, so if you need to calculate how much fluid should be given to the child, we can use this formula, 150-20 rule, or for maintenance fluids, and 4:2:1 rule for hourly rate of maintenance fluid. So always they say that before starting IV fluids, check serum electrolytes. So whenever child comes to you with dehydration, we have to check serum electrolytes including sodium, potassium, chloride. Very important. In children, all maintenance fluids should have a dextrose component. So whenever we are going to give maintenance fluids to the child, we have to give dextrose due to their higher risk of hypoglycemia. Okay, so child is suffering from dehydration, we have to prevent hypoglycemia, so we need to give some dextrose as well. Common IV fluid combination, IV normal saline is the first line, bolus for children with significant hypovolemia or significant dehydration, and bolus is there, and then the maintenance fluid is there. If there's a newborn, then there's 10% dextrose water we give. For the first month of life, 5% dextrose water and 0.5% normal saline and potassium chloride, all three are added. And only add potassium chloride if voiding well, means if the child is urinating well, then we have to give potassium chloride, add that as well, and especially if the potassium is getting low. Okay, children without special considerations, dextrose water 5%, or normal saline plus KCl, decreased risk of hyponatremia. Okay, the most important thing to remember when correcting sodium due to fluid deficit risk of cerebral edema with rapid dehydration with hypotonic or isotonic solution. We don't have to rapidly rehydrate a child. It can lead to cerebral edema. Always remember rapid rehydration with a saline with hypertonic or isotonic solutions of normal saline, it can risk formation of cerebral edema. Therefore, replace fluid slowly with close monitoring. We have to replace the fluid slowly with close monitoring. Aim to adjust plasma sodium by no more than 12. Management depends upon etiology, severity, and timing. Next thing is continue to monitor fluid electrolyte balance. Accurate monitoring of daily fluid intake per oral and IV and ongoing losses. We need to monitor each and everything. If child is saving more than 50% maintenance fluid through IV, serum electrolytes should be monitored daily and therapy adjusted. Avoid iatrogenic hypernatremia. We don't have to either increase sodium in the body or decrease sodium in the body. Therefore, we will have to be very careful while resuscitating the child with fluids and electrolytes as well. Next topic that we need to cover in gastrointestinal in the unit is gastroenterology of the pediatrics is vomiting. Okay, we have to take a careful history. What is the type of vomiting? Is projectile vomiters, bilious or bloody? Pattern association with fields is cyclic, morning, prolonged, positional. And the symptoms diagnosis of appetite, diarrhea, abdominal pain, hematochezia. Other GI symptoms we need to ask as well. Then fever and headaches, etc. Sick contacts, history of chronic recurrent infections. Okay, some non-specific symptoms are prolonged vomiting. If it occurs more than 12 hours in neonate, newborns, more than 24 hours in children, less than 2 years, more than 48 hours in children, more than 2 years, profound lethargy, significant weight loss, GI obstruction, then there will be bilious vomiting, projectile vomiting, hematitis. So all these things need to be asked in history. Neurological or systemic disease, bulging fontanelle, headache, altered consciousness, focal deficits, history of trauma. Remember that vomiting without diarrhea is not always gastroenteritis. It can be DKA. So only vomiting and no diarrhea. It's not always, we don't say it's always gastro. No, it's not always gastro. It can be DKA. Post-tussive vomiting common with coughing fits like whooping cough. There will be vomiting after coughing. That is called whooping cough. Okay, physical vital signs we need to check to determine the clinical status and dehydration. Abdominal examination for obstruction or focal pain or tenderness. Neurological assessment for signs of raised ICP. Next thing is investigation should be guided by presentation history physical. If child appears well and no features of an investigation not required. We have to do certain list of investigations: CBC, electrolyte, urea creatinine, amylase and lipase. Amylase and lipase are basically pancreatic enzymes, glucose, liver enzymes, and urine analysis. In sick child, add CRP, inflammatory markers, venous blood gases, culture and sensitivity of blood and stool, and imaging X-ray ultrasound. So all these are the lab investigations we need to perform. So next important table is basically table 22, and you can see page 42 of pediatrics if you want to follow me along with your books. So let's see this table and understand what's written inside. So here is a comprehensive table which shows various differential diagnoses of vomiting, the findings and the diagnostic approach. The first thing is neonates, which are newborns, and the non-bilious vomiting is there. They say the first cause can be tracheoesophageal fistula formation. What happens that the child can present with excessive secretions soon after birth. There will be drooling, there will be choking, there will be respiratory distress or pneumonia, inability to feed, and cyanosis, especially with the feeds and vomiting. So soon after birth, all these things if happen, there will be secretions, there will be respiratory problems, there will be feeding problems, cyanosis, and vomiting. So inability to advance NG2, whenever we try to advance NG2, because we have to keep the child NPO in such a case. So we cannot advance NG tube because it's a fistula formation between the trachea and the esophagus. NG tube is placed in the esophagus and there is fistula, so therefore we cannot advance the NG tube. Chest X-ray we need to be done. Next thing is upper GI series with the water soluble contrast. We have to do upper GI endoscopy or something with water soluble contrast. Next thing we need to know about what is cause of vomiting in the newborn child. Pyloric stenosis, a projectile non-bilious emesis or vomiting within 30 minutes after feeding. So it is a projectile vomitus. Always remember non-bilious. Child presents with fatigue, dehydration, palpable olive in the right upper quadrant. This is a very good hint for scenarios regarding MCQs, that what is the shape of the palpable thing in the right upper quadrant, just like olive shape. So palpable olive in the right upper quadrant, there is decreased stools and the child will be extremely hungry. So we have to check all the things, CBC, electrolytes. Okay, we have to check creatinine, urea. We have to check ABGs. Okay, one thing I want you guys to remember, that in a case of pyloric stenosis, always remember few things in your mind. Repeat after me, guys. In pyloric stenosis, there will be projectile, P for pyloric and P for projectile, non-bilious vomiting. There will be one more P, palpable olive in the right upper quadrant. There will be ABG, the arterial blood gas, that may show hypokalemic, metabolic alkalosis. Repeat after me. Three main things in pyloric stenosis. First is projectile vomiting, non-bilious. Number 2, palpable olive in the right upper quadrant. Number 3, ABG shows hypochloremic, metabolic alkalosis. Okay, what is the diagnostic investigation of choice for pyloric stenosis? Ultrasound. Ultrasound is done to diagnose pyloric stenosis. Upper GI study if ultrasound is non-diagnostic. So, ultrasound is basically the diagnostic modality for pyloric stenosis, and upper GI study if ultrasound is non-diagnostic. Okay, ultrasound, upper GI study. So what are the two investigations we do for pyloric stenosis? First is for foremost and the most important is ultrasound, and number 2 if upper GI study if ultrasound is not diagnostic. Then the next thing we need to know about vomiting is causes of vomiting is GERD, gastroesophageal reflux disease. Fussiness after feeds. Whenever we feed the child feels so fussy and child is going to spit up. Child is arcing back and has a poor weight gain. Child is extremely fussy. He frequently spits up and there is a arcing of back and poor weight gain. Empiric trial of acid suppression. What we have to give? We have to give some general things like acid suppressants. We have to give acid suppression, some syrups to suppress the acid production. And also we can give PPIs, omeprazole, but little child alginate liquid or basically to suppress the acid. And then pH monitoring is very important. Upper GI study and endoscopy are investigations of choice. Upper GI study, endoscopy. Then sepsis. Okay, sepsis can, like gastroenteritis and those things, can also lead to vomiting. Fever will be there, lethargy, increased heart rate, increased respiratory rate, widening of pulse pressure. So all the labs are important. CBC, PTA, PTT, electrolytes, urea, creatinine, LFTs, bilirubin, lactate, urine analysis and culture and X-ray. Okay, inborn error of metabolism. One more thing causing vomiting can be inborn error of metabolism. Poor feeding will be there. The child will be especially show poor feeding. He will show failure to thrive, jaundice. Child will show liver and spleen enlargement. Okay. So I wanted to show you guys that okay, the liver and spleen gets enlarged because of inborn errors of metabolism, right? Then there may be cardiomyopathy, heart problem, developmental delay, neurological problem. So There may be liver spleen enlargement, there may be heart problems, there may be neurological involvement in inborn errors of metabolism, right? So the diagnostic approach again will be number of investigation, electrolytes, starting from electrolytes, ABGs, okay, then lactate, ammonia, LFTs, urea, creatinine, glucose, bilirubin, PTA, PTT, CBC. Whatever investigation comes to your mind, just remember for this purpose. Okay, next thing is neonates with bilious vomiting. Okay, so all these were non-bilious, no bile in the vomiters, non-bilious. Now neonates with bilious vomiting. Okay, that can be a hint for MCQ purpose as well. That if they say non-bilious vomiting, keep those things in mind that we just read. All those things that we just read. Next thing is non-bilious vomiting. We have to remember these things in our mind. First is intestinal obstruction, malrotation with volvulus, okay, and meconium ileus. So intestinal obstruction is the number one thing. Either they can be volvulus or meconium ileus. There will be bilious vomiting, abdominal distension, bloody stool. Okay, and for this purpose we need to do abdominal X-ray, upper GI series, contrast anemia, abdominal ultrasound to check any superior mesenteric artery and vein relationship. But more important, I think, in case of intestinal obstruction is do the abdominal X-ray and upper GI series. Okay, then the next thing we need to know about is duodenal atresia or stenosis. Duodenal atresia, again there will be bilious vomiting where there will be bile in the vomiters. There will be abdominal distension, often seen in jaundice, polyhydramnios, hypokalemic. Okay, again here the ABG will show the same picture like the pyloric stenosis I shared with you guys, hypokalemic, hypochloremic, metabolic alkalosis. Okay, and the duodenal atresia may present with bilious vomiting. One thing we need to remember: abdominal distension, jaundice, and polyhydramnios during pregnancy. Okay, the mom has polyhydramnios during pregnancy. What should come in your mind? Duodenal atresia. Okay, to diagnose this condition, we do abdominal X-ray. Upper GI series will show double bubble sign. Abdominal X-ray and the upper GI series show double bubble sign. So remember, D for duodenal atresia, D for double bubble signs. Duodenal atresia is double bubble sign. Next thing we need to remember is Hirschsprung disease. Hirschsprung disease, again there will be bilious vomiting, there will be abdominal distension and pain and failure to pass stool. Always remember, Hirschsprung disease can lead to toxic megacolon, and there will be constipation, and the child is unable to pass meconium soon after birth. As a result, there can be abdominal distension. So what we have to do: abdominal X-ray, easy investigation, but the diagnostic definitive one is contrast anemia. And then the rectal biopsy is definitely the most important one. So abdominal X-ray, contrast anemia, and rectal biopsy. Rectal biopsy is the definitive diagnosis for making the definitive diagnosis. Number 4 thing is necrotizing enterocolitis. Especially happens in the premature neonates. Bilious vomiting will be there, will be blood in the stool, abdominal distension, cannot tolerate feeds. So again we have to do abdominal X-ray. We have to check CBC, electrolytes, urea creatinine, and blood culture. Alright, I move forward towards the next thing, that is what happens, what are the causes of vomiting in children and adolescents. Alright, okay, so let's read about it. Acute viral gastro is a very common thing, we all know about it. Again, with vomiting there will be fever, there will be diarrhea, there will be tummy pain, there will be pain in the muscles, and travel history might be there. Okay, and usually it's a clinical diagnosis, but if severe, we have to check CBC, electrolyte, stool studies, these things. Okay, appendicitis, again we know there's a periumbilical discomfort, later localizes to the right lower quadrant or the right iliac fossa. There will be fever and loss of appetite. Abdominal ultrasound is the diagnostic modality of choice, especially in children and adolescents. Alright, next, intussusception. colicky, progressive abdominal pain, drawing of legs up to chest. That is basically the child draw legs up to chest. There will be lethargy, bloody, red currant, jelly stool. Okay, if you see the word red currant jelly stool in stem, and the child presenting with vomiting and tummy pain, excessive crying, and bloody stool, red currant jelly stool. Always remember the diagnosis into susception. Again, ultrasound is a diagnosis and abdominal X-ray to rule out other causes. Then non-GI infections including meningitis, pyelonephritis, kidney infection, brain infection, acute otitis media can be there, and we have to check the cultures for whatever infection we are suspecting. We have to do the culture. We have to do the blood culture, the urine culture, or CSF culture, and brain imaging, X-ray as well. Then the next thing, of vomiting cause can be increased ICP, nocturnal awakening, frequent awakening in the night time, progressive recurrent headache, worsen with Valsalva, early morning headache, or then we have recurrent headaches, worsen with Valsalva maneuver, focal neurological deficits and gait problems. Okay, focal neurological deficit and gait problem. Okay, now next thing is brain CT without contrast or MRI. Brain CT is important. Then therapeutic lumbar puncture in idiopathic intracranial hypertension. Okay, then the next thing is toxin ingestion. Findings vary by substance. Okay, and qualitative and sometimes quantitative levels in urine and blood. Pregnancy, there can be vomiting, amenorrhea will be there, morning sickness, bloating, breast tenderness, and we have to check urine beta acidity, urine pregnancy test. Then cyclical vomiting, at least 3 self-limited episodes of vomiting lasting 12 hours. Okay, so there are at least 3 episodes of vomiting that last 12 hours. 7 days before between episodes, no organic cause of vomiting. So basically 7 days between the episodes and no organic cause of vomiting. This is basically a diagnosis of exclusion. Okay, at least 3 self-limited episodes of vomiting lasting 12 hours, 7 days between episodes and no organic cause of vomiting. These are diagnosis of exclusion. So 3 episodes lasting 12 hours, 7 day between episodes and no organic cause. Okay, the management of vomiting is basically, of course, rehydration. We have to maintain the fluid electrolytes. We have to treat to manage underlying cause, correct metabolic electrolyte abnormalities. Antiemetic drugs can be used in older infant, children, adolescents with severe vomiting. What are the name of antiemetic drugs? First name is ordancetrone, promethazine, prochlorperazine, metoclopramide. So all these antiemetics names we should remember, we should keep in mind. Starting from ondansetron, number 2 promethazine, then again one more P, prochlorperazine, and number 4 is metoclopramide. Okay, not recommended when unknown etiology, so we don't give it when we don't know the etiology. Okay, all right. Next topic I'm going to cover is GERD. Gastroesophageal reflux disease, extremely common in infancy. Okay, passage of stomach contents into esophagus causing regurgitation or vomiting that can happen soon after feeding. Okay, we feed the child, soon after that the child vomits out the food, and there will be non-bilious, rarely contains blood. Okay, gastroesophageal reflux causes troublesome symptoms like infant. What will happen in infant, what will happen in older child or adolescent, I will discuss with you guys. The symptoms are important to diagnose the GERD. All right, so in case of infant, the infant will be having poor weight gain. Of course, if the child is not able to tolerate the diet, the liquid food or whatever we are giving to the little child, so infant, so there will be poor weight gain because constant regurgitation or vomiting is happening. There will be irritability, child will be extremely irritable, sleep disturbance, cannot sleep properly. Respiratory symptoms can be there like coughing and choking and wheezing. Coughing and choking and wheezing. All right. And then older child will be, there may be tummy pain, heartburn symptoms, difficulty in swallowing, asthma-like symptoms, upper pneumonia, upper respiratory tract infections, if there is aspiration of things, aspiration of fluids, so they can lead to aspiration pneumonias. Recurrent otitis media means middle ear infections, upper airway symptoms and dental erosions, weight loss, excessive irritability, and nocturnal vomiting. Vomiting, especially in the night time. So, all these things are related to the symptoms of GERD in infant and older children. Differential diagnosis, okay, just a rough idea. Some GI disorders, neurological disorders, metabolic disorders, cardiac disorders, infections, renal, others, okay. Then investigations we need to keep in mind. What investigations we need to do for GERD? Okay, guys, so the investigations for case of GERD is thriving baby requires no investigation. So if the child is thriving, no significant problems with the child like weight gain and those things. The weight gain is fine, everything is fine, no investigations. But the GERD generally can be a clinical diagnosis. Diagnostic investigations rarely done but may include upper GI series, assess anatomy and motility disorder. Upper GI series that basically assess anatomy and the motility movement disorder. Esophageal pH, assess frequency and duration of acid exposure, not a definitive diagnostic test and not often done. Okay, and the number three thing is upper endoscopy and esophageal biopsy. So there will be upper endoscopy and esophageal biopsy. Rule out other conditions that mimic GERD symptoms. Eosinophilic esophagitis, assess GERD-related esophageal injury. So the GERD can be a clinical diagnosis involving basically upper GI series, esophageal pH, assessing frequency and duration of acid exposure, and then upper endoscopy and esophageal biopsy to rule out other conditions that mimic the GERD symptoms. And then we have to assess the GERD related esophageal injury. Warning signs of associated disorders requiring for so bilious vomiting is a warning sign. GI tract bleeding, of course, forceful vomiting, retching, forceful vomiting, fever, lethargy, liver spleen enlargement, bulging fontanelles, microcephaly, macrocephaly, seizures, abdominal tenderness or distension, suspected genetic and metabolic syndrome or chronic disease. Management is like these are all various red flags in case of GERD. So all these things, if any such thing such happen, we have to treat immediately. We have to take it serious. Okay. Then the management is basically conservative, and conservative management includes the infant. If comes to you with GERD, we have to ask the mom to give thickened feeds, like thickened feeds to the infant, frequent and smaller feeds, elevation of head, changing formula to hydrolyzed protein amino acid based formula, starting solid foods if age appropriate. So for infants, the thickened feeds are needed, frequent small feeds are needed, head elevation is important, changing formula to hydrolyzed formula, and starting solid foods if age appropriate. For breastfeeding infants, elimination of sequential elimination diet by mother, including milk, beef, soya, and eggs. The mother has to restrict using all these products like milk and milk products and beef and soya and egg. Older children, same as adult management, that is use of PPIs, omeprazole, lansoprazole, lifestyle changes. Medical management is use of PPIs, ACE2 blockers, which are used as acid suppressants, decrease gastric acidity and decrease esophageal irritation. So definitely acid is low, esophageal irritation is low. Recommended when failure of conservative measures happen, moderate to severe disease or biopsy proven esophagitis. Then the next thing is D2 antagonists. D2 antagonists basically include domperidone and metoclopramide. Domperidone and metoclopramide is basically D2 antagonist, generally not recommended for GERD, reserved for concurrent gastroparesis. So what we need to give D2 antagonists, dopamine antagonists like domperidone, metoclopramide. So we can give acid suppressants like antihistamines, and we can give PPIs, and then we have to use certain dopamine antagonists like metoclopramide and domperidone. And acid suppressants are not recommended for infants with uncomplicated reflux. Uncomplicated reflux, don't give too much medication to a small infant. Then interventional medication, like when there is a failure of medical therapy, if GERD is not an isolated diagnosis, then we have to do some surgeries like Nissen fundoplication, insertion of gastrojejunal tube or post pyloric field, gastrojejunal tube insertion, and Nissen fundoplication. Several of these recommendations should be used cautiously, giving high risk of necrotizing enterocolitis. What are the complications of GERD? There may be esophagitis. There may be oral feeding aversion, poor weight gain, strictures, and maybe development of Barrett esophagus. Next thing we need to cover today is diarrhea. Okay, what is diarrhea? Diarrhea is defined as an increase in the frequency or decreased in the consistency of stools compared to normal. Normal stool volume, infant 5 to 10 gram per kg per day, children 200. So basically there's decreased consistency, increased frequency, that is diarrhea. Okay, so diarrhea definition varies with diet and age. Stool normalcy difficult to define in children. In infants, what can happen? There can be increase in the frequency of the stool to twice as often per day. An older child 3 plus loose or water stool per day. Okay, so infants twice frequency is there, or older children 3 plus stool frequency per day. Duration, if it happens less than 2 weeks, continues for less than 2 weeks, acute diarrhea. If it stays for more than 2 weeks, then it's called chronic diarrhea. Okay, then we have history, frequency, duration. We need to check the frequency, duration, quality of diarrhea. Associated symptoms like fever, vomiting, abdominal pain, hematochezia. Hematochezia is basically blood in the stool. Blood in the diarrhea is known as hematochezia. Diarrhea red flags, bloody diarrhea, bloody stool, fever, petechiae or purpura. Signs of severe dehydration can be there, and weight loss and failure to thrive. So all these things, if they happen to a child, these are basically the red flags. Next thing is associated symptoms we need to know. Then recent antibiotic use can also lead to which type of diarrhea? Clostridium difficile diarrhea can occur because of use of antibiotics like fluoroquinolones, clindamycin, and penicillins and cephalosporins. So this can be an MCQ, that the child was taking these antibiotics like cephalosporins, fluoroquinolones, clindamycin, penicillin, and diarrhea happened. So what is this diarrhea called? This is known as Clostridium difficile diarrhea. Okay, or travel history can be there, elements of diet. Okay, now we have to check the signs of the child, like we have to check the dehydration status and everything. Okay, investigations, acute diarrhea, what we need to do. Okay, acute diarrhea of well child with non-bloody diarrhea often requires no further investigation. Okay, we don't need any investigations for acute cases of diarrhea which are non-bloody. Otherwise, we need to check stool for culture and sensitivity, stool culture, electron microscopy for various viruses, very important. Stool PCR tests and Clostridium difficile checking, blood and urine culture, CBC electrolytes, urea, creatinine, glucose, abdominal imaging. But these are especially investigations are done if you are suspicious of something that is not settling, and we have red flags present, so definitely do these investigations. But for chronic diarrhea, as stays more than 2 weeks, then is known as chronic diarrhea. Am I right? Is it 2 weeks? Yes. If it stays more than 2 weeks, then it's called chronic diarrhea. And what investigations we need to do in such children? We need to check monitoring of height, weight, and growth. We need to monitor height, weight, and growth on specific charts called growth charts. If child is growing well and thriving, workup is limited. Stool cultures as above, stool reducing substance. If child is growing well and thriving, so we don't have to do so much investigations. But red flags, like, keep in mind the red flags. The child is not growing well. There is rash, there is blood in the stool, there is vomiting, abdominal distension, hospitalizations frequently for dehydration. We need to do the full blood workup. Alright, next thing is the following investigations are guided by the differential diagnosis. Okay, so for stool, we need to check the consistency, pH, microscopy of culture sensitivity, occult blood, then Clostridium difficile toxin, fecal fat, fecal elastase, then urine analysis and urine culture is important, CBC, all the blood tests important, CBC, ESR, CRP, electrolytes, total protein, albumin, calcium, potassium, and all the electrolytes, and PTA, PTT, INR. Then the sweat chloride test, celiac screen, thyroid function test, urine VMA, HVA, or of course, we don't have to do all these investigations in a single infant. We only have to do when we have specific suspicions in mind. Like, if you are suspecting celiac disease, we are going to do the celiac screen. If you are suspecting cystic fibrosis, we are going to do the sweat chloride test. If we are suspecting hyperthyroidism, we will do the thyroid function test. Understand? Okay. Another things can be X-ray, upper GI series, specialized test, endoscopy, bowel biopsy. Alright. Now the differential diagnosis of diarrhea, just like we read differential diagnosis of vomiting, now diarrhea. So the acute diarrhea, of course, infections are the most common causes. Viral infections, bacterial infections, and parasitic infections. What viral? Rotavirus, Norwalk, enteric. I think rotavirus is the most common cause of viral diarrhea. Viral diarrhea, rotavirus. Bacterial, Salmonella, Shigella, Campylobacter, E. coli, Clostridium difficile, and Yersinia. So, what are the bacterial causes? E. coli, Salmonella, Shigella, Campylobacter, Yersinia, Clostridium difficile. Then parasitic, Giardia lamblia causes giardiasis and Amoeba histolytica. So Giardia lamblia and Amoeba histolytica, they are both parasites, so they can cause parasitic acute diarrhea. Non-infection causes, of course, if the use of antibiotic Clostridium, then the diarrhea name is Clostridium difficile diarrhea. Then non-specific associated with systemic infections, Hirschsprung disease, toxic megacolon, toxin ingestions, and intussusception. These are not infectious. Okay, chronic diarrhea, infectious chronic diarrhea. In if it happens in 0 to 3 months, can be G infection can be the cause, or then maybe some food protein or allergies or milk protein allergies or Hirschsprung disease. If it happens between 3 months to 3 years, GI infection again, and one thing called toddler diarrhea and celiac disease. 3 to 18 year again, GI infection, lactase deficiency, irritable IBS, irritable bowel syndrome, IBD, IBD, endocrine causes, neoplastic. Uncommon or drug induced chronic constipation can also lead to diarrhea. UTIs can lead to diarrhea. Short bowel syndrome, HIV. Okay, just a rough idea of what are the differential diagnosis of diarrhea. Now the management: correct fluid electrolyte losses, administer appropriate nutrition, including zinc supplementation and vitamin A supplementation, assess need for antibiotics, improve public health, involvement of public health if needed. Prevention is vaccination against measles, rotavirus, and cholera, and breastfeeding, good hygiene, optimal nutritional status. Next thing is the topic of gastroenteritis. And the gastroenteritis is presenting with diarrhea, vomiting, fever, anorexia, loss of appetite, headache, pain in the muscle, pain in the joints, abdominal cramps. Bacterial viral causes are most common. Bacterial parasitic more common in older children. Recent infectious contact symptoms begin 24 to 48 hours, 1 to 2 days after exposure. Fever is there, dehydration is there, investigation not usually necessary in young children, but some blood work like CBC, electrolyte stool studies indicated in severe cases if IV dehydration required or atypical, then we have to do investigations, microbiological testing for immunocompromised hosts in children with atypical features. Alright, viral, fecal viral assays can be done. Okay, bacterial CBC, we have to check the neutrophilic count, stool cultures, parasitic elevated eosinophilic count, stool examination. Complications, hemolytic uremic syndrome can happen due to sugar toxin producing E. coli. So remember, E. coli, sugar toxin producing E. coli. E. coli enterotoxigenic can cause HUS. Viral gastro usually self-limiting. 3 to 7 days it can last and then it resolves. Adverse effects related to hypovolemia can happen definitely, and shock can happen, and acidosis can happen. Okay, death is severe dehydration. If the child gets severely dehydrated, death can even happen. Okay, gastroenteritis, where viral and bacterial, how to differentiate between the two? So the most common is viral, and the rotavirus is the most common. Other causes can be norovirus, enteric adenovirus. Bacterial infections, again, all the names that we already read: Salmonella, Shigella, Campylobacter, E. coli, and Yersinia. So, viral infection and viral diarrhea, okay, or viral gastro associated with upper respiratory tract infections resolves in 3 to 7 days. There will be mild fever, malaise, vomiting, and vague abdominal pain. But bacterial infection, there will be severe abdominal pain, high fever, and there will be bloody diarrhea. So blood is there, high fever is there, severe pain is there. Severe tummy pain, high fever, bloody diarrhea. Suspicion should be bacterial infection. Risk factors are common for both of them, like daycare, young age, sick contact, immunocompromised status. And for bacterial infection, maybe travel history, poorly cooked meat, poorly refrigerated foods, antibiotics. Management, treatment of dehydration, very important. Early refeeding advisable. Okay, zinc is needed, or dalcetone is being given as antiemetic for gastro, or antibiotics, antiparasitic when indicated. Antidiarrheals are not given. Notify public health authority. Promote regular hand washing. Return to school 24 hours after the last episode to prevent transmission, and prevention with the help of rotavirus vaccine. So next thing that we need to know about is toddlers diarrhea, that happens in the toddler age. Okay, more common in between 1 to 3 years of age and resolves after 4 years. Diagnosis of exclusion, maybe many bowel movements, 4 to 6 bowel movements per day. Dietary history is very important. Okay, maybe the child is drinking too much juice. Stool may contain undigested food particles, and there may be diaper rash. For investigations, we need to check height, weight, and growth percentiles on the growth chart. No routine investigations are needed if the child is otherwise well and growing appropriately. If child is unwell, then we do the stool sample and analysis. Stool sample analysis if the child is unwell. Management is reassurance that it is self-limiting. Reassurance that it is self-limiting. Okay, what is the other management that we need to remember? Adequate fiber, fluid, fat is low, and discourage excess fruit juice. Okay, 4 F's are there. We have to give adequate fluids, we have to give fiber, fluids, low fat, and low fruit juice. So two things we need to increase, like fiber we need to increase, fluids we need to increase, and the two things like dietary fat we need to decrease, and fruit juice we need to decrease. Okay, now the next thing is lactase deficiency, also called lactose intolerance. What is that? In this case, in lactose intolerance individuals or children, there will be chronic for long term. Watery diarrhea can be there. There will be tummy pain, bloating associated with dairy intake. Okay, whenever child takes some dairy food or any dairy products, there will be bloating, there will be diarrhea and abdominal pain. Primary lactose intolerance may be crampy abdominal pain with a loose stool. Okay, and a secondary in lactose intolerance, there will be older infant persistent diarrhea. Okay, so diagnosis investigation not needed. Trial of lactose free diet is needed. Symptom associated assessment with validated questionnaire. Positive hydrogen breath test. One test is important, hydrogen breath test. If more than 6 years after oral lactose load, simultaneous symptoms assessment, like test for lactase deficiency. Okay, and genetic testing, lactase deficiency test and genetic testing. Okay, the management is basically you have to give lactose free diet and lactase containing tablets, capsules or drops. And lactase containing tablets, capsule or drop, IB. Then celiac disease more given in basically gastro chapter, and we will read in detail in that chapter. And then a celiac disease diet must avoid gluten. Gluten is present in barley, rye, oats, and wheat. Barley, rye, oat, and wheat should be avoided because it contains gluten. Barley, rye, oat, and wheat. But oats are there seeing controversial. But barley, rye, wheat, 100% we need to avoid in a case of celiac disease. Okay. Next thing is cow milk protein allergy. This is the last topic I'm going to cover for today. So, what is cow milk protein allergy? Maybe either IgE mediated or maybe a non IgE mediated, okay, which is further classified as a food protein induced allergic proctose, such a fancy name, food protein induced enterocolitis syndrome, or food protein induced enteropathy. Okay, fancy names are there. Okay, some clinical features of IgE mediated cow milk allergy. So, what happens in the case of IgE mediated? Occurs within hours of exposure, present on the skin. There may be itching, urticaria, pruritus, upper and lower respiratory tract symptoms. There may be wheeze and cough, and gastrointestinal symptoms, for example, tummy pain, nausea and vomiting and diarrhea. Nausea, vomiting, diarrhea, tummy pain, and maybe respiratory tract symptoms like maybe wheeze or cough. Okay, next thing is non-IgE mediated cow milk allergy. So, what is a non-IgE mediated? Reactions occur hours following ingestion, presents with mild diarrhea, a small amount of bloody stools, severe vomiting and diarrhea, anemia, hematochezia. Okay, if there is a mild diarrhea and small bloody stools, severe vomiting, diarrhea, anemia, hematochezia. Okay, up to 50% of children intolerant to cow's milk may be intolerant to soya protein as well. If it's intolerant to cow's milk, may be intolerant to soya protein as well. Investigation. Food challenge gold standard, skin prick test, serum measurement of allergic specific IgE, and the patch testing. Okay, so we have to do the food challenge test, the skin prick test, and patch testing. Okay, IgE mediated stop exposure epinephrine, non IgE mediated stop exposure reintroduce milk at basically 6 to 8 months. Casein hydrolysate formula or mother may sequentially remove cow's milk protein. Okay, all bovine protein, soya protein, legumes, continue breastfeeding. Okay, all these things are casein hydrolysate formula. Okay, casein hydrolysate. So basically, extensively hydrolyzed formula, removal of cow's milk from the mother's diet, then the use of soya protein, legumes. Okay, Give breastfeeding to the child with adequate calcium and vitamin D intake. All right, thank you so much for being with me during this session. And today we covered many topics related to GIT. We did cover some important causes of dehydration in detail, then causes of vomiting and diarrhea in detail, and see you soon in another session. And if you are liking these sessions, please give a thumbs up and like and comment and share these videos, and please subscribe to my channel. Thanks and have a great day everyone. See you soon. Take care. Bye.